MAGA takes another swipe at Medicaid. RFK Jr. dodges another vaccine question, and wow, some of these appointees have some weird opinions about COVID vaccines. This is America Dissected. I'm your host, Dr. Abdul and Katelyn.
And I'm your co-host, Dr. Katelyn.
And we're recording this on Tuesday, May 20th at 1:30 p.m. Eastern Time. So, Katelyn, hot off the presses, can you give us the new official guidance of the United States of America Department of Health and Human Services?
Yeah, so this is hot off the presses. So we just got word about an hour ago before this recording. But the FDA commissioner and Marty Makary and his advisor, Vinay Prasad, unveiled a major shift in U.S. COVID vaccine policy. So this is just focused on COVID. They dropped a New England Journal of Medicine perspective piece, as well as did a live FDA event, like fireside chat about this. Basically, what they're doing is COVID-19 vaccines will now only be recommended for people over 65 or at least with one chronic conditions. If manufacturers want to offer vaccines to younger adults or pregnant women, they have to run a new placebo-controlled trial. And it sounds like before each season that this virus changes. Their reasoning was because there's more population level immunity right now, and the original trials basically no longer apply. Now, on the surface, right, this sounds like a reasonable reevaluation, right? After all, severe COVID is less common in healthy young people. There are legitimate questions, right? Whether we need annual boosters and if they're still recommended and needed for everyone. But Abdul, I'll be honest, like what's really troubling to me is what's more below the surface, that this is completely bypassing rigorous, transparent systems designed to evaluate vaccine policy and replacing it with political theater and contrarian ideology. I mean, basically what's happening right now is that two people at the FDA, not based on any new evidence, no new data, no external committee that is open for the public to understand, is making a decision for all Americans that this is how COVID vaccine policy should work. And it completely bypasses the science-based system. It's setting up a really, honestly, legal and ethical bind for CDC and undercutting the work that's already done there. And just also a plain unattainable goal. And they know this. And they know better. Abdul, I mean, what jumps out at you with all of this announcement?
So a couple of things. Number one, the more limitations they put on the vaccine, implicitly or explicitly, the more, by definition, they draw questions in the public mind about these vaccines, right? And that, to me, is in keeping with the general approach that we've seen with this administration about telling people to take the vaccine, but asking so many questions that at some point there's a subtext where, oh, but there's also worries here, right? You hear it out of RFK himself. You're hearing it here. The second point is this sort of interesting double play that they're trying to do with bureaucracy. On the one hand, they say, well, we don't believe that the current systems actually are as rigorous as we want, but we can't really set up the systems that we really want. So now we'll just kind of shoot from the hip. Exactly. So we'll just be like shoot from the hip and say, we'll just set some approaches. But we really, really do believe that we need rigorous bureaucracy. And they know that it's not possible to set up in the amount of time that we have the kind of randomized control trial that you need. Because here's the thing. Their point is one, and let me see if I can explain this because it's a subtle one, but it's important to understand. Their point is that the current level of background immunity that we have is so high that old data does not apply. So you actually have to try the vaccine in the real world environment in which it's being deployed. Here's the hard part though. COVID is seasonal. So by definition, if you wanted to do an RCT where you were testing this in the real world circumstances, you would need to wait until the season in which COVID vaccines were needed most to really test whether or not they're safe, effective, et cetera, et cetera, et cetera. So that would mean we would go a whole season in which you would need an RCT. But then if they're saying that you need a new RCT every single year, by definition, you don't have the data you need because you want the protection in the moment in which you would actually have to test the vaccine. So like you're setting up a logical impossibility and then hiding behind that logical impossibility to say, well, in the absence of what we actually need, we'll just kind of take all the power and bypass all the bureaucracy that has been set up already. And so I'd love to have some clarification about how they're thinking about that. So if they said, look, we want one season to update, and up until then, the current background approach applies, I'd say, that makes logical sense. All right, it's been 6 years since these vaccines came out. We're going to do another background RCT with updated immunity numbers to understand who's at highest benefit here, and we're going to update accordingly. But until then, we're going to grandfather in one more year according to old guidelines. I'd be like, okay, that's a fair approach. That's a very, very fair approach. But that's not what they're doing, right? They're saying we're going to 100% change the guidelines based on our opinions, and then we're going to do another RCT, which we understand, we know, right, we can't actually do. And by the way, we're going to have it done every single year. And that's the thing that I'm a little bit frustrated by. I'm a lot of bit frustrated by.
Yeah, I mean, so during the FDA Live event, Vinay clarified that he doesn't think an RCT is needed every year, just once the virus has shifted. It's called antigenic shift. But once it's shifted, it's too late. Like we've already learned this with flu. Like this whole reactive versus proactive approach is just like not how you get ahead of viruses and infectious diseases. The other thing that kind of did surprise me, and they also know better, is that the ethical implications of giving saline vaccines in a randomized controlled trial, because they are calling for saline vaccines. They're not calling to test whether a formula shift is a bit better than before. They just want a random, IRBs, institutional review committee boards that review the ethics of studies, they just wouldn't allow this. Like it's just not,
yeah,
it's just not ethical. And so they're purposefully binding the hands. And this is just not what Americans deserve. Like I'm really quite shocked about how much they are doing right now to undermine the scientific processes we have.
The point that you make about, there's a fancy ethical term called equipoise, which is to say that you can't ask somebody to do something that will put them at risk relative to the best known available treatment. So for example, we don't have randomized controlled trials about the causal consequences of smoking. And the reason why is because the minute you hypothesize that smoking is bad for somebody, you can't actually ask them to smoke. So similarly, right, the minute you hypothesize that a COVID vaccine is good for somebody, you actually can't withhold a COVID vaccine from somebody for the purposes of your study, even if you need that to have, right, the kind of causal inference that you would like. So to your point, Katelyn, the thing that you would do is you would test a new vaccine relative to the old vaccine, which would then give you answers about how much better a new vaccine is. The other point is that, like, what does this pretend about the notion that antigenic shift can only happen once? Like, once we've undergone antigenic shift, then we will test the new vaccine. We're like, okay, it can happen multiple times in a season, actually. So like, which one are you actually testing? Exactly. Yeah. So it doesn't really pass muster. On that note, look, it'll be interesting to see as this gets formalized and where we go from here. We do have some time for the process to play itself out into the fall. And I do think that there's going to be, from unfortunately, the way I think this is going to work is there's going to be a lot of other voices who are saying the exact same things that we are. And I'm interested to see how they respond, right? Because my sense is that this is not the be all and end all, make public policy by town hall here. So let's move on to our, their boss, RFK Jr. And
here
last week, he appeared before the House and Senate. And Katelyn, you did an amazing job recapping that in short order for us last week. I do want to play one clip from the hearing because that's the one that got echoed through the internets. And I do want to talk about it. The first voice you're going to hear is Democratic Congressman Representative Mark Pocan, and then Robert F. Kennedy's response. Take a listen.
If you had a child today, would you vaccinate that child for measles?
For measles, probably for measles. What I would say is my opinions about vaccines are irrelevant. I don't think people should be taking medical advice
Right.
from me.
I mean, so you're the goddamn Secretary of Health and Human Services of the United States of America. You spent the entire decade before you became Secretary of HHS, which, by the way, you got that job because you ran for president on a whim and then dropped out and endorsed the guy who ultimately won. You spent that whole decade trying to provide medical advice. And now that you got the job that you said you wanted and you traded your presidential campaign for, you don't want people to listen to your medical advice? I mean, this is the problem. This is the dog that caught the car and doesn't really know what to do with it. And the problem with it is that he doesn't want to face the accountability of all the bullshit that he got away with before he was ever in a role where people actually had to listen to him and he was shaping public policy when it comes to public health. I mean, we just had a whole conversation about the COVID vaccines. The notion that somehow he has no impact on that. One of the number one peddlers of mis and disinformation about COVID vaccines, the notion that he does not have impact on what is now being recommended is insane. And for him to sit in that hearing room and to say that it doesn't really matter what he thinks is just the worst kind of attempt to slip the accountability that should come with being willing to be the HHS secretary. And I don't know what else to say about that except for to say, like, these are the people who are now making public policy and they don't want to be held accountable for the terrible things that happen when people actually listen to what they have to say.
I agree. And I see it. It's not just accountability too. I mean, we're hurtling towards this really new and dangerous, I guess I'm going to say, normal, where public health is framed as this personal burden, right? It's not a collective good, that it's your job to diagnose your own illness. It's your job to fact check your doctor. It's your job to do the research. It's your job to question the vaccine schedule or filter out falsehoods and rumors or distinguish good science from snake oil, like all alone. And I'm a mom that is really busy. I mean, I go to a car mechanic and I trust them to look at my car because they have the expertise to do that. And I actually very much appreciate not having that burden to have to do that sort of research on my own. And it's not just RFK, right? Dr. Oz has said this too, that like it's your patriotic duty to be healthy. It's just this radical individualism that's being dressed up as empowerment, but I see it as honestly more abandonment. And RFK, I mean, he's in charge of these systems that are supposed to help Americans make their lives easier and healthier. And by putting the onus all on the individual, it's just dangerous. And he knows he has the influence on health policy around vaccines. And he knows his megaphone alone can cause enormous harm. And that's what we're seeing unfold here.
There's another really dangerous implicit argument that's being made is when you say that it's now your job to control your own health, to do your own research, to figure it out for yourself. What you're doing is implicitly stepping away from all of the spaces of public health that you can't do for yourself.
Systems.
And when you think about the quality of the air you breathe or the quality of the water you drink, those aren't things that you as an individual can necessarily control unless you have huge amounts of money, right? And so for most people, the water they drink is downstream of a water system that is regulated by government policy. When you think about the air that you breathe, that's downstream of government policy regulating what gets put in the air. And when you submit to this idea that health is only a set of choices that you as an individual make, you have to wonder whether or not there's a purposive stepping away from the broader questions around what government needs to do to protect you from the likes of corporations. And when you connect the dots with all of the other things that this administration is doing, that to me is a very, very dangerous thing, because once you start deregulating what a corporation can do and say, well, it's your job to be healthy, right? Then you start to recognize the intellectual infrastructure underneath. Well, it's not government's job to regulate a corporation and their smokestacks anyway. Well, it's not government's job to protect you from a PFAS plume being put in the ground by some corporation just dumping its fallout from its manufacturing process in your local stream. And that is really, really dangerous. And guess who it affects the most, right? It affects folks who don't have the means to be able to step in and like finite control those things. And, you know, when you look at the Maha folks, right, they tend to be a couple things. They tend to be disproportionately rich and tend to be disproportionately white, right? And I just want to say that, right, because there's a lot of privilege that goes into being able to actually control all the things about your health, right? Like if you want to go get a full battery of your blood test every 6 months, cool, go do that. But that's expensive, and don't ask everybody else to spend money on that, because that should just be included for you in a basket of goods we include in universal health coverage. But we don't have that. And so you can go and spend on your own, and that's a thing that you can take on. But look, for a lot of people, that is unattainable, like let alone just breathing clean air, right? Because you're living in a community where a long time ago, they just zoned you in with a whole bunch of corporations that that can poison your air and force you to breathe it. So that's the thing to me that I think is just really worrying. And I think all of us need to be able to call that out when you start seeing the second order consequences of deregulation in situations of public health.
Right. And it's the same sort of theme that's happening in Florida right now with fluoride. The state lawmakers just voted last week to remove fluoride from their drinking water. Utah already outlawed fluoride. I know a number of states are already kind of considering this. And again, it's removing system level protection, the exact thing that the U.S. government is supposed to be doing, and helping Americans live more healthy and prosperous lives. I did some digging into this Florida situation because I was curious, right? Like, first of all, not everyone gets fluoride in the United States. About 70% get fluoride added to their water. Some Americans have it added naturally. It's a natural substance. But so in Florida, 80% of residents currently receive fluorinated water. So that means on July 1st, all of this will go away this summer. Interestingly, the state has one of the lowest dentist to patient ratios in the country, as 82% of Floridians live in an area designated to have a shortage of dental health professionals. And get this, 18% of Florida dentists accept Medicaid, meaning 82% of dentists don't accept Medicaid. And so what we're seeing, I wrote, is a massive uncontrolled experiment, right? That is the intersection of removing protections, but then not also replacing them with more dentists or more access to healthcare or other means for people to protect themselves. And Abdul, I just keep asking myself, like, how did we get here? How did we get here?
Yeah, I really appreciate that. You know, we've had a couple of episodes with experts, and I encourage folks to go back into the episodes, and maybe we'll link them in the notes some of the episodes we've done on this. But, you know, we discovered that fluoride had pretty incredible implications for dental health almost by accident, right? And so we started to add it in very small amounts to water because it had massive implications for the ability to protect tooth enamel from dental caries. It's a fancy way of saying cavities. And just so folks understand what a cavity is, it is literally bacteria burrowing into your dental enamel such that it literally will destroy a tooth once it gets into the pulp of the tooth, like the soft part. And so this has been massive in terms of reducing the number of dental caries, improving dental health overall. Now, just as soon as we started to add fluoride into water in the post-World War II era in 1945, you saw the stepwise rise of an anti-fluoride movement started in 1950s and 60s, but it's always been fringe, right? It was sort of one of those things that the John Birch Society took up, and they said that fluoride was part of a dangerous communist plot. And so it's been fringe for a while, but it's sort of come back into vogue with the rise of RFK Jr., who added fluoride to a number of other issues that really were about trying to undermine the traditional scientific expertise and the things that government public health has long done. And he said that, I quote, "It is an industrial waste associated with arthritis, bone fractures, bone cancer, IQ loss, neurodevelopmental disorders, and thyroid disease." Now, here's the thing about it. Like, you know, what he doesn't say is that there is a dose response related with anything that you put in. At a small dose, some things can be really, really healthy. At a large dose, some things can be really, really toxic. So think vitamins A, D, E, and K, which are all things that are absolutely necessary for you to be able to thrive. And they're vitamins that you can overdose on and ultimately can cause you very, very serious illness. So fluoride in a small amount is one thing, but to say that because of fluoride in large amounts being able to cause some sort of toxicity, that somehow all fluoride is bad. And all of that leads to this point that this man has no concept of how science works, right? It is not, I could sit here and say the same exact things about vitamin D, right? I could sit here and say that vitamin D is associated with toxicity, because that's true in very, very large amounts. It's also something that's absolutely necessary. Yes, water, right? You can get water toxicity. Like, you can get water drunk. If you drink too much water, it literally can kill you, right? But without water, 70% of your body, you die. So this is just an insane approach to taking what seems like scientific language with no scientific undergirding or understanding, and then peddling mis and disinformation. Now, the fact that it has been public policy to add fluoride to water has had huge impacts on people's well-being. And so, it is sad to see where we've gotten to, and the fact that there are going to be a lot of people who suffer at the same time when, by the way, they're trying to cut benefits that get people who otherwise can't see a dentist to a dentist. Like, you can't make it make sense. I mean, it's just so hard because, I keep trying to tell my mind, like, oh, let me try to connect that. No, there are no dots to connect. There's actually, this is just an incoherent spaghetti of ideas that have been tied together because they sound good on the fucking internet. It makes zero sense. I'll stop there.
Yeah, I agree. I think the other thing that's really fascinating that especially with this Florida decision, was that, let's back up a little. Fluoride in water is actually a very hyper local decision made by the county or municipal water works. Interesting, though, that now Florida is taking that hyper local decision away from the county and local level, and basically saying at a state level, we don't believe in this. This is not what your community needs. Very top-down approach. And it's just the hypocrisy that comes through around this, and wanting to control narrative and policy on a state level when really local control is where this is needed, is beyond me. Again, trying to make it make sense, and it doesn't.
No, it's anti-conservative. Like, that's the thing. It's anti-conservative logic, right? No, because conservative logic was always that you should have local control and that we should devolve decisions to the lowest level so that every community could have as much control as they possibly could have. And now you have this administration literally coming in from the top down and trying to truck all of the other lower levels of government and take away their right to self-determination. It is anti-conservative. And so the hypocrisy, to your point, is profound, because you're violating your own principles so that you can, win a meme war on the internet. And meanwhile, there are a bunch of folks in these communities that are going to suffer.
Yeah, it's not like this costs much. The other thing that's happening is not just this local control, but it goes back to your point, Abdul, about them taking away the tools for people, like cutting Medicaid access if they want to go to a dentist, but also, okay, so say you take away fluoride from your water. We have lots of Americans that don't have fluorinated water, but what they do get is this oral fluoride supplements that are on the market from the FDA. And at the same time that this is happening last week, the FDA also announced that they've begun to remove oral fluoride supplements from the market. And so again, you're giving less and less and less tools for Americans to stay healthy. And it's really hard. It's hard to watch.
Yeah. And again, based on the flimsiest associations of high fluoride levels with bad outcomes, right? Like, this would be like saying you're going to eliminate vitamin D because at very, very high levels, vitamin D is toxic, right? It just does not make any logical, evidence-driven sense. But it's based on the flimsiest understanding of the weaponization of this sort of science speak around associations to make very, very bad public policy. So I do want to move into, more on Medicaid and SNAP, because last week we talked about how the Republican budget proposal to cut Medicaid funding was going to be moving through this week. It's made it through the House Budget Committee, and so it is potentially on track to be passed. And if it was to be passed, 9 million people could lose their healthcare coverage. But as if that wasn't harsh enough, a number of Republican lawmakers, they refused to vote in the Budget Committee, saying that the cuts needed to be deeper. And they wanted the Medicaid work requirements to take effect faster. And they wanted tighter restrictions to make sure that undocumented immigrants couldn't access Medicaid. And I just want to be clear about this for a minute, right? Number one, Work requirements add so much waste to a program. Like the minute we call this means testing in the public policy space, right? And the thing about means testing is that you have to set up a whole infrastructure to make sure that there are some people who don't get the service rather than investing your whole budget in providing the service. So it is definitionally wasteful and it's not really effective. But what it does do is it creates the narrative that there's fraud and abuse, because every once in a while people get through your bullshit means testing that's a waste of money. And then you can point to them and see, oh, look, this is fraudulent and abusive. So it sets up for even more cuts later on. Like that's the game here. And I just want people to understand it. The other thing I want you to think a little bit about is, if you've got people in this country who can't get healthcare, who, I don't know, might be working in agriculture in a situation where they could be exposed to H5N1, bird flu, like you kind of want them to get healthcare. Like you want them to be able to come to care somewhere, to be able to get care and get the services that they need. So maybe they don't spread infectious diseases to everybody. And so it's irrational to rob healthcare of anyone. Like this is one of those things that everyone should have because it's better for all of us when people have it. But, right, in their logic, they don't want to give any quarter or any services to anybody who could be undocumented, lest it waste our tax dollars. But don't forget that a lot of undocumented people actually pay into Medicare and Medicaid. Like on net, they end up paying more than they get. So it's kind of this is entirely about messaging and symbolism. America Dissected is brought to you by the de Beaumont Foundation. For 25 years, the de Beaumont Foundation has worked to create practical solutions that improve the health of communities across the country. The foundation advances policy, builds partnerships, and strengthens systems to give everyone the opportunity to achieve their best possible health. To learn more, visit debeaumont.org. So I do want to move on to another piece, right? Just another terrible consequence of this bill is that it doesn't just cut Medicaid, it also cuts SNAP. Can you talk to us a little bit about the SNAP program and what it would mean to lose access to that for millions of people in our country?
Yeah, so SNAP is basically, in the old days, this was known as food stamps, but a ton of Americans qualify for SNAP benefits. 42 million, and they get federal money to buy groceries to literally feed themselves. So this last draft proposed cutting SNAP in 4 ways. One, cost sharing mandates for states, which means that states with higher poverty, basically who need SNAP the most, may not be able to make up the cost. 2, stricter work requirements. So parents with children over the age of 7 would be required to meet work requirements rather than the current exemption of 18. 3, reduce federal reimbursement for state SNAP admin costs, which will likely reduce states' capacity to just run SNAP efficiently. And then 4th, eliminate SNAP education, which is the education arm of SNAP to help educate about the importance, get this, of healthy food choices, which is actually an incredible thing that we need, we're cutting right now. So,
but Katelyn, wait! I thought everybody was supposed to do their own research. I thought they were supposed to. I thought they were supposed to make their own decisions. So we're gonna cut the program that like teaches people about how to eat more healthy, and then tell people they just got to do their own research. So like what? They just got to follow RFK Jr. on social media?
Yeah,
like just insanity.
I think you would like that. It is, yeah. There's a number of senators that have already said they're not going to pass this SNAP bill, which I guess is good news. I don't even know how it got to the table in the first place. So it'll be interesting to see where SNAP actually lands with all of these more rounds of negotiations to go. But man, what a place to start from.
Yeah. I mean, literally taking food off the table for families. Like that's what this is.
Yeah.
And
literally,
the thing I want people to understand, like these are like the majority of people who benefit from these services tend to live in communities that are represented by people who are going to be voting to take them away. Like it is wild. Like you just got to understand that the transfer here. It's like we're going to take resources from you so we can pass a tax cut to the people who pay for a lot of these campaigns. Like that's what the transaction is. So, I mean, literally robbing food off the table for babies and moms and parents and seniors and all of these folks. And, we're not even going to tell you what you should eat healthy. Like, so the little money that you do have, we're not even going to give you any guidance about how to eat healthier. It's like cruel. I mean, it's just cruel. It's like, it's cruel and unusual. And this is in the richest, most powerful country in the world. Like, it just, yeah,
It's hard to
stupid
believe.
shit.
Yeah, it is.
All right. Well, we got to finish on some good news here, Katelyn. There's a little baby who
So cute.
had a really terrible and very, very life-threatening genetic disorder. And this week, we learned that the baby had been like miraculously cured by DNA editing technology that literally went in and just changed the baby's DNA so that the kid just didn't have this genetic disorder anymore. Can you tell us a bit more about it, Katelyn?
Yeah, so what the scientists use is this thing called CRISPR, actually the newest version. So it's like CRISPR 2.0. And basically what they did was
So like
they
even crispier?
CRISPR. God, the dad joke. And so what they tried, this is serious, Abdul. What they basically went in is try to fix this deadly genetic mutation. This baby had this rare disease that causes toxic ammonia to really build up in the body. And it often requires a liver transplant. The challenge, though, is many babies die before they grow old enough to have a liver transplant. So the doctors in Philadelphia use CRISPR to correct like this exact mutation. It was basically a typo that they were fixing in a Word document, right? It's like editing this within the DNA. It's the first time it's ever been done. And we don't know if it's a cure yet. I don't think we can get too excited yet, but this baby's hitting all the milestones, off all the meds, has recovered from 2 viral infections, and is just fine and so cute. And so, I mean, yeah, this is a huge deal in science. It's so cool because, it's not just about this little baby, but it's a breakthrough that could open the door for thousands of rare genetic diseases, right? Ones that were usually considered hopeless, honestly. I think it's really quite amazing what science can do. And we need to keep reminding ourselves of this while NIH has 40% budget to be cut.
I was like, who's going to go there first?
Okay.
I mean,
No,
that's the
but this
thing,
is
right?
good
Like
news.
this CRISPR-Cas technology is truly incredible. It allows you to go into a genome and basically do control, find, replace, right? And that is something we couldn't have imagined doing in the past. And it opens up a level of in vivo, which is like in people, biological alteration that could address the foundations of genetic disorders in some really huge ways. And to see it used in this particular case is extremely exciting. But to your point, Katelyn, that is the consequences of a lot of research that was NIH funded in the past. And so when you start cutting that research now, what you're doing is you're robbing the future of the next advancement that could fundamentally change the way that we think about disease. And so research funding always looks wasteful because you're looking for a needle in a haystack. And when most of the time all you find is hay, you're like, oh, what's the point of this? We're just finding hay. And you're like, yes, you kind of have to keep looking at the hay to find the needle. And when you find the needle, it really is miraculous. And this is just another example of that.
Incredible. All right, Abdul, who did you interview this week?
We had a great conversation with Dr. Aaron Kesselheim. He is like truly one of the world's experts on prescription drugs in the United States. He's both a doctor and a lawyer, and he teaches at Harvard. So like if you've ever had CV envy, like Aaron Kesselheim is the person that your parents wanted you to be. So he's on today. He's talking to us about the rather spineless executive order that Donald Trump signed last week on prescription drugs and what the alternative could look like if we were serious about reducing prescription drug prices in America.
Can I just say, Aaron also helped me last week, and your local epidemiologist. I threw something at him after an introduction from you, Abdul, around. I really wanted people. I mean, people were having a billion questions about drug prices, like why is it high, et cetera. And so you connected us with Aaron, and he is brilliant at explaining this sort of stuff. I mean, I learned so much of just doing these 10 FAQs around drug prices. So everyone, definitely stick around because he knows his stuff really well and it's fascinating. And also has a lot of insight on what can be done to decrease drug prices because they are ridiculously high.
It's interesting because in this moment, we're taught that, one ought not to fully trust the experts all the time. And that's in part because most people's interactions with experts are in these like little sound bites. You don't really start to appreciate what true expertise is until you start to ask people questions, and then they show their thinking and their logic, and you just realize the depth of what it takes to truly know something very well, right? And Aaron is one of those people who, as someone who's like literally written books about this stuff, like when I want to feel dumb about our healthcare system, I go sit with Aaron Kesselheim on prescription drugs and be like, oh, yes, okay.
But he's so patient. And
he really
he's
is.
so good at explaining it from a place of empathy. And so like, I too feel very dumb about this, but like he was great anyways. And it takes teamwork, right? Like I'm just an epidemiologist and all of these topics are coming at 2,000 miles per hour. So it was quite an honor to tap Aaron to help with this. And so shout out to Aaron out there.
All right. Can you introduce yourself for the tape?
My name is Aaron Kesselheim. I'm a primary care doctor, lawyer, and professor of medicine at Harvard Medical School and Brigham and Women's Hospital, where I lead the program on regulation, therapeutics, and law.
And if you've ever been compared to somebody by your parents in not so great a light, Aaron is that guy. So Aaron, thank you so much because you're our resident prescription drug expert here on AD. This is, I think, your third time on the show. We're super excited to have you because, of course, there's a lot of news relevant to prescription drugs, prescription drug prices. And I wanted to, jump in just because the latest news is about this executive order from the Trump administration on most favored nation clause. Can you break down how this is supposed to work and then what your general thoughts on it are?
Sure. So a couple days ago, the Trump administration issued an executive order basically requesting pharmaceutical companies lower their prices to what's called what they're calling the most favored nation, which is the lowest price that those drugs are available at in a number of similar sized European countries. And basically the issue here is that in the United States, we pay for brand name drugs about 2 to 3 more than European and Canadian and Australian and other people in other high income settings pay for the very same drugs made by the very same manufacturers. And the reason is because after a drug is approved in the United States, we allow drug manufacturers to charge whatever they want. In those other countries, there's a second step in which they then evaluate the benefits of the drug and use that information to negotiate a price on behalf of the government. And so what Trump is basically saying is that he wants drug manufacturers to sell the drugs in the United States at the lowest price that they're negotiating the price for in one of these other countries. So that's the basic theory behind it. The problem is, of course, is that it's not clear that he has the authority to do that just by issuing an executive order. And in fact, he tried to do it in his first term. At the very, very end of his first term, he tried to do it with some rulemaking through CMS that would have set up a voluntary model for companies to do this, and that ended up getting shot down in the court. So I think that if Trump really did want to do this, he'd have to do it through legislation. So I don't really think that it is that putting it through an executive order is any kind of credible threat that this will actually happen. And in fact, the day that he issued the executive order, pharmaceutical stocks went up, like during his speech, with the recognition that, I think from the investors that this is all just a bunch of hot air.
Wow. So their response was basically like, oh, if this is it, then we're good.
That's right.
That's wild. So the EO, per what you're sharing here, doesn't really have teeth, and it's unclear whether or not an executive order could have teeth, which has been, I hate to say it, the theme of this administration. Do a lot of things by executive order, but without the kind of teeth that you really would want to see or have. Now, the question here is, let's just say they actually were able to pass this in legislation. What are your thoughts in terms of what that would do if this was legislation, if it did in fact have teeth? What do you think the consequence would look like? Because my sense is that it would then create an unintended consequence, which is now where pharma would now start to try and push a lot harder in these negotiations across the world rather than just simply sort of take it? How do you think about that?
Well, I think that you're exactly right, that there would be a lot of unintended collateral effects if the U.S. did base its prices entirely on what other countries were paying. So, for example, you could imagine a scenario where drug companies would not release the price that they're paying in other countries, so that the U.S. would not be able to know exactly what the price was. Or they would release the drug in a slightly different formulation. Instead of a 25 milligram dose, in Germany, it would be a 30 milligram dose, so that we would not be able to exactly replicate what the price would be in the United States. Or maybe they would delay the approval of the drug in those other countries to try to ensure that they extracted the maximum price they could from the United States before they started making the drug available in other places. So you can imagine a whole host of unintended consequences that would come from the United States doing this, which is why fundamentally, even though it is true that patients in the United States pay too much money for brand name prescription drugs, and we should pay fairer prices that are more based on the value of the drugs, the best way for us to do that would be for us to evaluate the benefits of each drug as they're approved ourselves, and negotiate ourselves with the manufacturers in the United States. Again, this is the same thing that all these other countries do, and there's no reason that a country that as large and as with as much resources as we have is not doing that sort of thing ourselves. In fact, this is what the Inflation Reduction Act that Joe Biden passed does, but it has a waiting period of 9 to 13 years for drugs, and only applies to a very small number of top-selling drugs. And so I think what we should be doing is, shortly after drugs are approved by the FDA, is undertaking this kind of a process then.
So there's a couple of things I want to pick apart there, because I think it's really just important context here. Why do other countries so clearly do it this way where our country does not? Let's start there. Like, why is that? Isn't it just baseline obvious that in our country we don't negotiate as a matter of course for prescription drugs, which, by the way, our taxpayer dollars disproportionately pay for the research and development of?
Well, I mean, I think that there are certainly historical reasons why we don't do it. In 2006, when Medicare Part D was created, which is the Medicare that covers outpatient drugs, it was actually written into the law that Medicare was not allowed to negotiate the prices of these drugs. For drugs covered by Medicare Part B, when Medicare Part B was created in the 1960s, we didn't really have a problem of a lot of very expensive drugs that doctors would deliver in the hospitals, just because there just weren't as many drugs available then as there are now. So we just never really historically had this in the United States. And in the United States, the pharmaceutical industry is an extremely strong lobbying group, and gives money to legislators on both sides of the aisle. And this has caused a lot of inertia when it comes to trying to change the law. In other countries, they tend to have systems where the government will be involved in providing healthcare coverage much more broadly than our government is. And in those countries, it was something that they did kind of as a matter of course, like, we're going to negotiate the prices of drugs in these countries. It was sort of set up in as part of their national legal structure in the way that it just was never created here.
Yeah. And, as so many issues do, it kind of goes back to campaign finance, right? The pharmaceutical industry is the single biggest lobbyist by sector, spending 4.2 to 4.4 billion over the last 20 years lobbying. And that lobbying, well, it buys you policy. And we see it in the context of the extremely pervasive structure for prescription drug price setting. And so we end up paying substantially more than any other country in the world. And we saw in the Inflation Reduction Act an attempt to try and address that. And obviously you and I were both intimately involved in thinking through that and some of the early research that went into what ultimately became the policy. But jog our memory here, right? We do have prescription drug price negotiation, 10 drugs at a time that meet very particular criteria. Can you walk us through what some of those criteria are?
Sure. So, in order for a drug to be negotiated under the Inflation Reduction Act, it has to be a top-selling drug, which means that it has to have greater than $200 million of revenue in Medicare per year. It has to be it has to have been on the market. I told you there's this waiting period where a drug has to have been on the market for at least 9 years if it's a small molecule chemical drug, or 13 years if it's a larger biologic drug. And then there are other exclusions, like, if there's a generic version or biosimilar version of the drug, it's excluded. If it's a drug that's approved only for a single rare disease, then it's excluded. And as you said, Medicare was given the authority to negotiate 10 drugs in the first year of the program. And this year, they have selected 15 drugs. Next year, they're going to select another 15 drugs. And then the year after that, I think it increases to 20 drugs per year. And so it's a small number of top selling drugs towards the end of their market exclusivity periods.
It's interesting. The pharmaceutical industry argues that if we were to wholesale start negotiating the prices of prescription drugs, that somehow this would be a damper on research and development for new medications in the pipeline. What do you make of that argument?
Well, I mean, I think that it is worth recognizing that pharmaceutical development is a costly process and a risky process, and we should make sure that there is a fair, that people can charge fair prices for the drugs that they invest money in. But I think it's also worth recognizing at the same time that we recognize those points. That a lot of the key innovation that goes into drug development is publicly funded through the NIH, and so a lot of the earliest stage, riskiest type of research that on which a lot of these drugs are based occurs at academic medical centers or government labs. I think it's also worth recognizing that large pharmaceutical companies spend only about 10 to 20% of their revenue on research, whereas more like 20 to 30% goes on marketing and administration and a salary, CEO salaries and those types of things. Another large percentage goes back to shareholders, and I think it's also worth recognizing that when we talk about a process for negotiating, where the negotiation occurs on the basis of the benefits that those drugs provide. So a very effective drug that meets an unmet medical need is going to extract a high price from a healthcare system that's as wealthy as ours. But what happens right now is that a lot of drugs that don't add a lot of benefits end up getting sold at very high prices, and we spend a lot of money on drugs that don't have a lot of benefits. So if we did have a system of negotiating prices, I think that it would actually improve innovation, because it would it would give fair compensation to really meaningful innovation, and it would give less compensation to less meaningful innovation. And I think that would send a very strong signal to the drug companies about investing in the most important, most meaningful innovation.
I really appreciate that point, that last point, right? Because so much of the way that we set prescription drug prices in this country is about the sort of way to extract a dollar in this sort of very complex financial transaction between payers and providers and pharmaceutical companies, right? And there's a lot of incentive to create another similar drug and take a bite out of a particular market rather than to innovate new medication. And so we've created a system where the NIH, mainly the NIH, but other publicly funded research will go into a lot of the riskiest research that then rolls out into the kinds of biotech companies that then get bought up by pharma and taken the rest of the way and brought to market. And then, as you said, a lot of the money is spent on those glossy pharmaceutical ads that color your airwaves, regardless of what you're watching on TV, rather than on a lot of that early research. What's frustrating, right, is that money was money we all paid into a system, and what happens is, a lot of that money, the majority of dollars spent in our system, gets spent by public funders of healthcare. So it's like the public pays for the initial research, and then on the back end, through programs like Medicare, the public pays these inflated prices. And who benefits, right? You got CEOs of major pharmaceuticals making tens of millions of dollars a year on the backs of ultimately what are public dollars that get plowed into the system. What's interesting, though, right, is that there is now a much more complex part of this that involves the back end, right? The sort of gutting of NIH, gutting of FDA, that also is a real threat. And I want to be clear, right? Because of how egregious the system I just described tends to be, there has been this wholesale loss of trust in even the medications and the science underneath pharma. And I think what you're seeing right now is the likes of an RFK Jr., who has been was the originator of the Maha pill, coming for the system as it stands as a whole, right? And I want to be very clear, the science that gets done through the NIH, that gets vetted through the FDA, is some of the best gold standard science out there, right? And scientists have to show their work. And so there's transparency, and you can see how the work gets funded and approved. The hard part is what happens in the financial transaction on the back end. But too often we've allowed the sort of cart to come before the horse on this. And so folks are just pitching the whole system out. And I worry about the consequences of that. And I want to ask you, what do you make of the implications of a lot of the changes in the funding structure at the NIH, and then certainly the regulatory apparatus at the FDA, and what the implications might be for the pipeline of new and important medications that can go on to save and improve lives?
Well, I think it is tragic and devastating what is going on right now. And it's kind of amusing that we're turning to talk to this after we just talked about how the pharmaceutical company complains about the Inflation Reduction Act killing innovation, where all that really does is try to make sure that we get a fair price for the drugs that are available. What we're talking about right now in terms of NIH cuts and FDA cuts, that's really what will kill innovation. And it's interesting that the pharmaceutical industry has not been talking, and sort of expressing substantial concern about this. But it is extremely damaging to be pulling billions of dollars out of a system that for decades has been the engine of therapeutic innovation in this country. All of the key drugs that you can think of. All the gene therapies that are currently available were developed based on public funding in academic settings. The cures for hepatitis C originated in public funding. Some of the key treatments for cancer, for HIV, all of the most transformative drugs and treatments that we have originate. And so it is beyond awful what is going on right now, and it is not something that we're necessarily going to see in a couple of weeks or a couple of months, but in years down the road, there will be substantial damage to our ability to bring new treatments to the market because of the completely unprincipled and thoughtless and totally radical cuts that are going on right now to the NIH and the research apparatus.
From your mind, obviously we've been covering this quite a bit on the pod, but as someone who's paying attention to the pharmaceutical side of things most closely, are there aspects of this that to you are more astounding than others?
I mean, I think all of it is completely unprecedented and astounding, and has, to be honest, taken a lot of the research enterprise by surprise, because there have been shifts in administration before from Democrat to Republican and from Republican to Democrat, but science has never stopped. And
Yeah.
what the people in the current administration have done by pausing funding, by stopping grant committees from meeting, by pulling funding from the system, by stopping grants entirely, by targeting academic centers and universities and stopping their funding, is they are stopping science from happening. And so I think it's just completely unprecedented and completely just kind of malicious in how they are undermining scientists' abilities to do the essential work that brings us the innovations that we need.
So you are coming to us from your position at the Brigham and Women's Hospital, one of the diamonds in the ring of academic medicine in America. Can you talk to us a little bit about what it feels like on the ground over there, what the impact has been on some of the research and on the institution that you work on, a place where some of the brightest minds in medicine have come through?
Yeah, I mean, it's a lot of doom and gloom. There are not only is it work that has been done for years that all of a sudden has to stop on a dime, which is wastes years and years of research and years of insights. Um, it's the the junior people who are thinking about going into science now have to wonder whether or not this is the right career for them. And so I think that we'll see people who won't necessarily pursue their interests in science, but will do something else, which is a massive hit to the to our ability in the future to sustain the levels of innovation that we've had. And I think that also, to be honest, people here on the ground are very concerned about the cuts to Medicaid that are coming down the pike as well, because so many of our patients depend on Medicaid in order to get the medications that they need, that have already been discovered and already out there. So I think that there's a lot of worry, not only on the science side of things, but also on the healthcare delivery side of things for what's going to come next from this government.
I really appreciate you sharing that, because I wanted to actually get there. What a lot of folks don't understand is a lot of our academic medical centers tend to be the medical provider of last resort in some of our lowest income communities. So you think about where like MGH is, for example, Massachusetts General Hospital. This is a hospital that faces Roxbury, one of the lowest income communities in Boston. You think about New York Presbyterian, where I went to medical school. You're in Washington Heights facing the Bronx. And you think about Hopkins in Baltimore. Now, a lot of these institutions haven't always been the best players, and we talked about some of that in a previous episode on debt. But a lot of them have, and they rely on Medicaid for part of their income, and so they've been caught between sort of a pincer move. On the one hand, losing a lot of the research infrastructure and grants and indirects that are so critical to funding them, and on the other, potentially facing Medicaid cuts that are critical for reimbursements from the patients that they take care of. Can you talk a little bit about how important Medicaid has been for research hospitals and our ability to provide high quality care, but also to do the kind of work that generalizes and helps us to better understand how to take care of patients?
I mean, it is fundamental because without Medicaid, it's the medical issues that patients have aren't going to stop. What's going to stop is their ability to have a system that is designed to care for them, so that they don't have to try to deal with these things on their own, or they don't have to show up into the emergency room and to try to just get sort of episodic care. Maybe at the point at which it's too late for them to intervene on their untreated diabetes or something. So Medicaid, which I think it provides a reasonable compensation, but it does not provide the greatest compensation for hospitals. But it does provide a baseline structure for patients to be able to get primary care and to be able to be plugged into a system where they can get specialist care, because there'll be a way for specialists to see them. And without that, patients will just be on their own, and it'll be up to individuals who might want to take on a charity case or two, and that is absolutely not the way to deliver proper care to patients. And so I think that it is Medicaid is truly a lifesaver for patients across this country. I think that the cuts that they're talking about right now are extremely concerning, that they'll be taking this away.
As we wrap here, I want to ask you, if you had a magic wand, and coming out of all of this with Trumpism and all of the challenges that we faced even before Trumpism, if you had a magic wand, what are the 3 or 4 things you would do to improve our both access, but also our research enterprise when it comes to prescription drugs?
Well, if I had a magic wand, the very first thing I would do is I would go back to 2024 and I would lower the price of eggs by about 50 cents. That's what just a few more thousand votes because of the price of eggs might have changed where we are right now. But then, of course, I would get a couple more wishes. Isn't that the way that it works with this thing?
Of course, the third wish is always for more wishes.
Always for more wishes, right? Yeah. So So first off, I mean, I think that we need to rethink all of these terrible cuts to the NIH and the science enterprise. In fact, we should be looking to increase the budget of NIH because it really is the basis on which innovation comes from. And so that would be the first step. I think the second step would be to again make sure that the FDA has the human resources and financial resources it needs to be able to make good decisions about whether or not drugs work or don't work. And I think it's terrible right now what they're doing, gutting the people who the workforce at the FDA and injecting political agendas into FDA decision making around vaccines. I think that all of that is really just going to lead to less useful innovation and more problematic, discussions or problematic information being circulated around treatments that actually do work. And then, I think the third thing that I would do, as we talked about at the beginning of our conversation, is that after drugs get approved, I think that it's reasonable to try to understand what kind of benefits they provide and how much we want to pay for those benefits, and then to try to make a decision about paying fairly for meaningful innovation, which I think sends the best signal for investing in that kind of innovation to begin with. And I think that if we did a lot of those things, then we would both get the drugs that we need, we would get them tested in rigorous ways before they were approved. And then when they were approved, they'd be available at reasonable prices that would help people access them. And so, but I think that unfortunately, in the last 3 or 4 months, we've been moving in the wrong direction on all of those different fronts.
Yeah. Well, I'm grateful to people like you who can remind us what the right direction is. And our hope is that even once this individual stops having his way, him and his minions stop having their way, that we can get around to trying to fix these problems. Because I think I really appreciate about what you shared is that there's a mistake that we sometimes make to assume that everything pre-Trump or pre-RFK now was great. And there were big structural issues. And although he's making them worse and tearing down institutions that were actually part of the solution, the question now is, okay, like what does it look like to actually rethink a lot of these things if we have the opportunity to build them from the ground up for the 21st century? And I think that insight is critical for us. Our guest today for the third time was Dr. Professor Aaron Kesselheim, Esquire, and grateful to you for joining us today and clarifying some of what's in this EO, why it probably won't work, and what really could work if we were serious about bringing down the price of prescription drugs. Really, really appreciate your time today.
Always a pleasure to join, Abdul.
That's it for today, and we're off next week for Memorial Day holiday. We'll see you back here on Thursday, June 5th. You can find more of our content at our website, incisionmedia.co, and check out our shop at store.americadissected.com for our America Dissected merch, which includes logo shirts, hoodies, and mugs. And don't miss out on our Make America Scientific Again caps. If you have guest recommendations for the show, do share them with us. Send us an email at info@incisionmedia.co. You can follow or subscribe to America Dissected on your favorite podcast platform and on YouTube at America Dissected. And you can follow me on Instagram, TikTok, and Twitter at Abdul Al Sayed. That's no dash. And don't forget to subscribe to Katelyn's incredible newsletter, Your Local Epidemiologist, which breaks down the latest scientific information for 300,000 readers. You can just search Your Local Epidemiologist on Substack. Finally, on your way out, don't forget to leave us a 5-star review. And if you're watching on YouTube, drop us a like or comment. Word of mouth still goes a long way, too. So if you know someone who might like to keep up with everything that's happening in the world of health, let them know. America Dissected is a product of Incision Media. Our co-host is Dr. Katelyn Gentilino. Our producer is Andy Gardner-Bernstein. Video and audio editing by Nadine Melkonian. Our theme song is by Taka Suzawa and Alex Sugiura. Sales and marketing by Joel Fowler and Nick Freeman at Big Little Media. Our executive producers are Tara Knight and me, Dr. Abdul Al Sayed, your host. Thanks for listening. This show is for general information and entertainment purposes only. It's not intended to provide specific healthcare or medical advice and should not be construed as providing healthcare or medical advice. Please consult your own physician with any questions related to your own health.